Hi, everybody. I wanted to chat with you for a few moments about some things that you need to pay particular attention to in Module 2. Um, First of all, Chapter 5 talks a lot about age-related changes, and we're going to be discussing those more in your body system presentations and in the discussion boards that will go with those presentations. So we're not going to spend any time together on Chapter 5 because we're going to be covering some of that information later. When you're thinking about assessing an older adult, there are some things you really need to pay attention to. A lot of the same rules that you use when you're assessing anybody else will definitely apply, but some things you need to pay particular attention to or that you need to be conscientious about when you're assessing an older adult is that you've got to take your time. You cannot rush through your assessment of the older adult. You've got to listen very patiently. Sometimes this can take a while, especially if you're dealing with somebody who has auditory or visual changes related to aging. It can take a long time to get an assessment on an older person. So you've got to listen patiently. You've got to allow for pauses in the conversation. If I tend to speak pretty rapidly, and if I do that when I'm assessing an older adult, I might lose them. They may not hear everything that I'm saying. So you need to take time and allow for pauses in the conversation, and you've got to be very careful to ask the right questions. Patients can be very good about answering questions the way we want them answered, and so you've got to be really careful to ask the right questions and to listen carefully to the answers that you're receiving. Another thing to really pay close attention to is that one thing that's crucial for us in this course is to be able to recognize the difference between normal age-related changes and pathology. So table 7-1 on page 93 gives you a really good brief overview of age-related changes related to your assessment. So when you begin assessing older adults, as you already have been doing in your med-surg class, but as you continue to think about assessing older adults, you need to recognize that age-related changes are different from pathology. And so things that are just normal age-related changes will not have to be reported to your physician, whereas pathology will be. So those are going to be really important things for us to remember as we move forward. The other thing to pay close attention or to be very conscientious about is to establish a good rapport. And this is going to be important with all patients, as we've done before, but it becomes especially important as we talk about the older adult. In a lot of these situations where a nurse is helping to take care of an older adult, it's going to be for a longer period of time. And so establishing that good rapport with them is going to be crucial from the very beginning. Let's talk for just a few minutes about your health history. Now, a lot of this will relate to the health history that you're going to be doing during this course. That is one of your major assignments. So this chapter is really important for us to pay close attention to. It's chapter 7. So what are some things that we need to think about when we're getting a good comprehensive health history on our older adults? And a lot of these will be the same as you would do for any other patient that you're assessing. But first is, of course, the patient profile. Where do they live? How old are they? What is their family support system? Part of your assignment, you're going to be thinking about their social resources and their economic resources. So this is going to be included in your patient profile. What are their available resources? Who do they have to help them? What money do they have to help them as they take care of themselves? Also, the past medical history is going to be super important. This is going to include medical history and their surgical history. So patients who have had a lot of medical history can have very complex cases going on. So if you have somebody who presents, for example, with abdominal pain, well, you need to know that they have had a previous colon resection, and maybe their abdominal pain is related to scar tissue or adhesions. Maybe they're taking an anticholinergic drug that is slowing down the gastric motility. So all of these things begin to play a part in maybe what their main complaint is or what brings them into the hospital. Review of systems is going to go right along with this. We need to know everything that's going on with every body system, because remember, one body system does not stand alone. They all interact. So we need to get a really good quality, thorough review of systems. Medication history. Now, is this only going to include our prescription medicines? Of course not. We also need to consider our over-the-counter medicines and supplements, and we're going to be talking in just a few minutes more about medication use. But to get a good, thorough medication history, and then a nutritional history as well is going to be important. Some of the other tools that are going to be helpful, and some of these you will be using when you do your health history, are the Braden scale, which all of you are very familiar with. Functional assessment is also important, thinking about how they get around. Are they able to perform their own ADLs? Neurological assessments, such as the mini-COG, which you'll be doing in your assessment, are important to help give you a baseline of their cognitive abilities. A fall scale, which you're also very familiar with, and a pain scale. Elimination screenings are also going to be important. What changes are they having related to their elimination, if any? They may not have any, but if they are they normal age-related changes, or is it something that really needs to be addressed? And as with any other history taking, documentation is going to be crucial, of course, so that we can make sure that we're communicating well between different medical providers. All right, let's chat for a few minutes about safe medication use. As you guys know from already having taken care of some older adults in the clinical setting, some of our older adults can take lots and lots of medications. People over the age of 65 make up 13% of the population, and they consume 33% of the prescribed medications. So think about that for a minute. 13% of the population consumes a third of the prescribed medicines, and 40% of over-the-counter medicines and supplements. So what does that mean for us as nurses? And that means when we're getting our medication histories, we have to ask some very specific questions. If they bring you a list and all that is on there is their prescribed medications, we've got to dig a little deeper and find out if they're taking any over-the-counter medications, supplements, or herbs to go along with that. And why is that going to be so important? Well, it's because of all of these adverse drug reactions that can occur. We'll talk some more about that in a few minutes. Let's think about the changes related to absorption, distribution, metabolism, and excretion that occur as a person gets older. So what's going on is related to absorption, where you're going to have changes in your gastric motility. You're going to have an increase in your gastric pH. Sometimes you can have a delayed stomach emptying. So what that means for us is that if we're giving a medication that we expect to be absorbed in a certain amount of time and there's delayed emptying of the stomach, their absorption time is going to be longer. So we have to be really careful about that when we're giving medications to our older adults. And we've also got to consider drug-to-drug interactions. If we have medications that are sitting in the stomach longer that are not emptying out, what is that going to mean for the way that those medications interact? Page 108 in your book, figure 8-1, is a really good visual to give you a picture of what some of those age-related changes look like related to pharmacodynamics. All right, let's talk about distribution. What's going on? Well, you're going to have changes in the way the body is distributed. So you're going to have a decreased lean body mass. You can have an increased body fat. And you can have a decreased total body water. So that's going to make a big difference in the way that these medications are going to be distributed throughout the body. What's going on with metabolism? What's going on with our liver as we begin to age? Since a lot of these medications will be metabolized through the liver, well, metabolism can decrease, or liver function can decrease, and therefore metabolism can decrease. So a lot of the dosages that we use for younger adults are not going to be appropriate for our older adults because of these changes. And the same is true for excretion. What's going on with our kidneys as we get older? Well, by the age of 80, your kidney function can decrease by as much as 50%. So what does that mean when you're thinking about excreting a lot of these medications we're giving to our patients? We have to be extra, extra careful when we start giving medications to older adults. And we have to take the way that the body is absorbing, distributing, metabolizing, and excreting these medications into account. All right, polypharmacy, what is that? Polypharmacy is defined as taking more than 5 medications at the same time. I know I have fallen into the definition of polypharmacy, even recently when I was so ill. So lots and lots of our patients deal with polypharmacy because 5 medications is not only prescribed medications, this is also over-the-counter herbs and supplements. So this can occur in a hurry. So what do we get so concerned about when we think about polypharmacy? Well, when you have all of these different medications and supplements and herbs interacting with each other, you have an increased risk for drug interactions. You have an increased risk of adverse events. Adverse drug reactions a lot of times are what brings older people to the hospital. A lot of times these do occur accidentally. It's not something that anybody has intended, but it's something that has to be dealt with when they begin to have trouble. So when we talk about an adverse event, what does that mean? That means it's a drug interaction or reaction. It can be an adverse drug withdrawal. All of a sudden they forgot to put their psychotropic medication in their medicine box, and so now they've had a sudden withdrawal from that and they're having trouble. Or it can be a therapeutic failure. Maybe in the past they've been able to tolerate 5 milligrams of Coumadin every day or warfarin every day, and now they've come in bleeding. Where in the past they've been able to metabolize that and tolerate that dosage, now they're no longer able to. So that's what we're thinking about when we're thinking about an adverse event. When we think about an adverse drug reaction, this is going to be an unwanted pharmacological effect. So this can be anything from a mild annoyance to allergic reactions to more severe things that are going on. Older adults are 4 times more likely to be hospitalized for adverse drug reactions than younger people are. So a lot of times that can be what brings our older adults into the hospital. And because of changes going on physiologically, changes in the diet, if somebody has all of a sudden become ill, that can definitely alter whether or not they can tolerate a drug. Just because they tolerate it now does not mean they can tolerate it later, depending on what's going on in their body. One thing we need to really pay close attention to, and we talked about this some in Med-Surg when we were talking about delirium and dementia, is that delirium and confusion can be induced by drugs, especially in the older adult, with all of the changes they have going on. So if you have a patient with sudden onset of confusion or lethargy or delirium, we really need to pay close attention to the medications and see if there's some sort of interaction going on that could be causing that. I think we often as nurses can overlook that and just quickly slap the label of dementia on somebody. So we've really got to pay attention to how medications can be related to changes in cognition. And because of this, advanced drug reactions can be unrecognized because we don't pay close enough attention. Page 114 of your book, box 8-2, gives you a good summary of some of these adverse drug reactions that can occur with different classes. So what happens when we think about misuse of drugs? Well, these are many times not intended. They do not intend to misuse drugs, but it occurs for lots of reasons. Say the patient goes to their cardiologist and then they turn around and go to their neurologist and they go back to their general practitioner. Well, unless the left hand knows what the right hand is doing, they can definitely be put on medications that should not be taken together. Other things that can go along with this are the cost of medications, language barriers, failures in memory as people get older, or vision or hearing deficits that they may have. Getting an accurate list of medicines can be hard. It can be really difficult. So one of the techniques that you can use is to have them, it's a brown bag approach, have them actually bring all of their medicines with them and make sure we have great communication between all of the healthcare providers. Remember too that blood levels are going to be super important to monitor in all patients, but especially as we're thinking about older adults and as their bodies are changing, we've got to be able to check those Lanoxin, the vancomycin, the INRs in our patients so that we make sure they're tolerating them appropriately. There's some ways that we can help prevent misuse of drugs or to have good communication, make sure that we're really looking at the environment carefully, reinforce teaching, make sure we know who the key people are in their lives who can help them with medicines, and to help avoid any drug interactions that could occur. So there's lots and lots to think about when we think about medications related to the older adult, but it's lots of things that are important for us to remember. And I want you guys to really focus in on this when we're thinking about when you're thinking about preventing polypharmacy in your patients.